Hi everyone, and welcome to the second workshop in our series on transforming health services in line with the government priorities. Before we start, I'd like to introduce ourselves. We are Unity Insights, a social enterprise embedded in the NHS, having historically been part of one of the health innovation networks. We have a vast experience of working with healthcare professionals, innovators and commissioners to support with NHS-specific challenges. I'm also sure you're wondering who we are and our roles at Unity Insights, so I'll first pass on to Ben, who will introduce himself. I don't know whether Ben's there. There we go.
Apologies. So I'm Ben Williams. I'm a senior analyst here at Unity Insights. I worked in healthcare analytics for about 19 years. Nowadays, I lead evaluations across a range of new technologies and pathway change, such as assessing the winter funding programmes in Sussex, evaluating the impact of a pregnancy education system, and evaluating the lipids and FH national spread programme.
Thanks, Ben. My name is Faye Maddock. I'm an analyst at Unity Insights. I've been with the team for just under 3 years now. And whilst being part of the team, I've used various analytical techniques in a wide range of projects, spanning from evaluating apps aiming to improve operational efficiency in healthcare settings to radiotherapy treatments for cancer. Today's focus is on how we can bring healthcare closer to home. We will go through the challenges related to this topic and how the government priorities aim to alleviate these issues. We will then highlight how we demonstrate the impact with a couple of examples before sharing with you our learnings and key takeaways. We'll take any questions in a Q&A session at the end, so please use the Q&A function to ask any questions that you have. First, let's start by going over the challenges faced and the ambition set by the government. One of the major challenges faced in primary care today is the difficulty patients encounter in securing GP appointments. The recent independent report by Lord Darzi highlights that GPs are seeing more patients than ever, but the number of fully qualified GPs relative to the population is falling. And this leads to increased waiting times and low patient satisfaction. The report also noted that there are huge and unwarranted variations in the number of patients per GP, and shortages are particularly acute in deprived communities. While life expectancy has increased, many people are living longer with complex chronic health conditions such as diabetes, cardiovascular disease, and dementia. This demographic shift puts extra strain on primary care services, which now need to manage patients with multiple comorbidities, and that requires more frequent and intensive interventions. There is also a growing gap between the demand for NHS and social care services and the system's ability to meet these needs. This results in a significant number of people going without the care that they require. For example, delayed social care can lead to preventable hospital admissions, and it can further complicate patient care, especially for the elderly and vulnerable. Recent years have seen more investment and growth in the acute hospital sector compared to the primary and community care sectors. Although this is the case, a well-resourced primary care system is really important for preventing hospital admissions and managing long-term conditions. The disparity in growth exacerbates pressures in hospitals as more patients end up needing acute care when earlier interventions in the community could have prevented this. Primary care continues to face severe staff shortages with too few GPs and allied health professionals to meet demand. This leads to heavier workloads for existing staff, causing increased stress, burnout, and ultimately staff leaving the profession. The impact is felt not only by the healthcare workers, but also by patients who face longer waits and reduced quality of care. Patient satisfaction with access to primary care services remains at a low level. For example, the GP survey indicates that many people feel they do not have easy access to their GP or primary care teams, exacerbating frustrations and undermining public trust in the system. The independent report from Lord Darzi highlights the importance of rebuilding public trust and confidence in the NHS. This dissatisfaction highlights the importance of improving both capacity and patient experience in primary care. So we know what the challenges are, but how do we alleviate them? As you know, the government set out priorities aiming to resolve the challenges faced in primary and community care services. The government aims to train 15,000 doctors a year, which doubles the current figure, in effort to help patients access timely GP appointments and increase resource available to prevent hospital admissions. This also aims to alleviate staff stress and burnout, as having more hands on deck will help increase capacity available. They also aim to guarantee face-to-face appointments when patients require one through training junior GPs. The government aims to deliver a modern appointment booking system to end the 8 a.m. rush, improving access to GP appointments, whilst increasing resource available to prevent hospital admissions and manage long-term conditions. Continuity of care for patients with long-term health conditions will also be incentivised to help those who are living for longer. A community pharmacy prescribing service will be created to help older adults with major health conditions. Trialling neighbourhood health centres will be completed through bringing together existing services such as family doctors, district nurses, physiotherapists, and so on, shifting resources to primary care and community services. If you combine all of the initiatives, this will hopefully result in better access, leading to improved overall satisfaction with primary and community care services. As you can see, these priorities will hopefully result in a lot of positive change in primary and community care. It's important that we ensure the most suitable innovations are implemented in the NHS as soon as possible to alleviate these challenges. Evaluations can help commissioners decide whether to adopt an innovation in the NHS, and that's where we come in. We have a vast experience of conducting evaluations to help understand how an innovation can help alleviate challenges faced in the NHS. Does it help with a particular ambition? Does it achieve what we want it to achieve? And what do you need to consider for innovations based outside of acute care settings? We take the learnings used from each evaluation that we conduct to gain more understanding on the challenges faced in primary and community care, and we then use these challenges and learnings in future evaluations. Our evaluations can often have a large impact on whether an innovation is commissioned, as we use real-world evidence to understand whether it achieves its aims. Today, we'll go through 2 case studies and highlight how we went about conducting the evaluation and how the findings link to the priorities set out by the government to demonstrate impact. One example of how we demonstrated impact was through an independent evaluation of Rapid Health Smart Triage system. In primary care, as I'm sure you'll know, patients experience difficulty in accessing GP appointments due to high demand of primary care services. Patients are seen on a first-come, first-served basis, where they often have to phone the practice at 8 a.m. to be in with a chance of receiving an appointment slot. This can lead to patients who need urgent care being unable to receive an appointment when they require one. Those who require care but cannot access care represent an unmet need, which is also increasing in size. As a result, staff satisfaction with access to primary care remains low. Rapid Health Smart Triage is an autonomous patient triaging system that aims to improve access for patients. Patients can request and book appointments online themselves, whilst also being able to request appointments in person and via telephone as before. The system then clinically triages the request and assigns a clinical urgency to allocate them a suitable appointment slot. We were commissioned by Health Innovation Kent Surrey Sussex and Rapid Health to evaluate the impact of Rapid Health Smart Triage within the Groves Medical Centre at the start of its deployment at the practice. Today, I'll highlight the methodology used within the evaluation, but we won't be presenting the results as these are still yet to be released. So, Rapid Health Smart Triage allows patients to request care themselves 24/7. And through being able to request care themselves, it's then expected that patients have an increased access to care. And that should then end the 8 a.m. rush, because patients can request care at any time. So they can request care at a time that's convenient to them by doing so online. Patients who would prefer to request care in person or over the phone should be able to do so at a time convenient to them, rather than at 8 a.m. Patients are triaged based on their urgency and availability, meaning that those with urgent needs receive an on-the-day appointment, and those with less urgent needs receive an appointment slot days in advance. Patients can select an appointment date and time that suits their needs, which is subject to availability. And this means that they can access care at a time convenient to them, thus improving their care experience further. Through triaging patients based on urgency and availability of appointments, it's then expected that waiting time should shorten, regardless of the patient's urgency. And this is then expected to further improve the care experience due to a decrease in patient deterioration. So here you can see how Rapid Health Smart Triage could contribute towards government priorities and aims to mitigate the current problems in primary care. So let's delve a little bit deeper into what we did for our evaluation. We conducted a mixed methods evaluation. So here we looked at quantitative insights from data related to the system. For example, we looked at data surrounding care requests made via Rapid Health Smart Triage. And this allowed us to understand who requested care, their level of urgency identified through the system, and so on. We also looked at appointments held at the practice before and after implementation to identify metrics such as the time taken from requesting to attending the appointment. And this allows us to understand whether the system does in fact help increase demand and capacity and reduce the 8 a.m. rush in line with the current challenges faced. When deciding how you want to conduct an evaluation, it's very important to identify and understand the questions that you're trying to answer. And once you know what questions that you aim to answer in the evaluation, you then need to identify suitable metrics to allow the questions to be answered, and understand what the findings gained from these figures actually mean in the real world. So what conclusions can be made due to the data. Then we also wanted to look at those impacted by the pathway and what they thought. So to do this, we gathered qualitative data through staff and patient surveys. And as we discussed before, the Darzi report noted the importance of trust and satisfaction within the NHS. So a great way to know if patients like a product is to complete patient surveys, and that way you understand their experience. Using a mixture of multiple choice questions and free text questions allows insights on patient perceived satisfaction levels, whilst also allowing patients to expand on their answers to understand why they may feel a certain way. And that can then create recommendations to improve an innovation, which can then further excel the success of an innovation. Overall, combining quantitative and qualitative insights allows us to obtain a holistic view to understand whether an innovation can mitigate a range of current challenges faced in primary and community care settings. Of course, the more challenges an innovation can fix whilst not causing any more challenges is going to make the best contribution in the NHS. A mixed methods evaluation can provide the evidence base to show how an innovation may contribute towards government priorities through lowering the impact of current issues. When we consider the current problems faced in primary care and the government's priorities, identifying the correct methodologies can help identify whether a solution does mitigate the challenges faced. It's essential to showcase evidence through independent evaluations to then increase the chance of further commissioning in more sites, fulfilling government priorities on a much wider scale. Although we can't share the results with you today, the evaluation does suggest that the solution yields some really positive outcomes, which is really great to hear. And without further ado, I'll now pass on to Ben for the next case study.
Thank you very much, Faye. So we mentioned earlier that there's challenges around accessing GP appointments, that people are living longer with more long-term conditions, and that there's been significantly more growth in acute sector spending versus other areas. So whilst this case study that I'm going to discuss with you today did aim to meet those challenges, it's also particularly interesting because while it required an immense amount of planning, it was necessarily reactive. So in terms of background, so seasonal flu places additional pressures in winter. A PCR test was developed, which enables testing for flu in the community. Normally, testing for flu only takes place in acute settings, with diagnosis in the community being based on expert opinion of GPs. Another consideration in the pathway is that patients tend to feel a cold coming on and simply self-medicate, initiating contact with healthcare professionals only once they deteriorate. We know that flu can be well treated if timely antivirals are provided, but by the time contact is initiated, it's often too late for the antivirals to have maximal impact. So with those considerations, what happened? Now, the aims of the programme are set out as below, namely improve patient outcomes, reduce burden on secondary care, and assess the acceptability of the pathway. So in a collaborative agreement alongside Health Innovation North West Coast, Roche Products and Roche Diagnostics, with support from Health Innovation Yorkshire and Humber, tests were carried out in 9 GP practices across the north of England between December 22 and March 23. The intervention population was anyone eligible for the flu vaccine, namely those aged over 65 or with a range of specific long-term conditions, and totaled around 43,000 people. Okay, so let's quickly talk about how we went about the evaluation. So this again was a mixed methods evaluation, including qual and quant, but also extending those findings to health economics to identify if and the extent to which this project represented value for money. The qualitative element was necessary to assess acceptability. This consisted of an initial survey with follow-up semi-structured interviews of staff, as well as interpretation of findings from interviews with patients that were undertaken by Health Innovation North West Coast's PPIET. The quantitative element was needed in order to answer the other two aims of improving outcomes and reducing burden on the health system. We included statistical testing, such as assigning p-values to the results to demonstrate the statistical significance, which in turn lent additional credence to the findings. Finally, the health economic element provided evidence around value for money and included 2 outputs. The first was a cost-benefit analysis, or CBA, which assessed the potential economic impact over 5 years, included sensitivity analysis using Monte Carlo simulation, and also had scenarios for spread. The second output was a budget impact model, excuse me, a budget impact model, or BIM, which is an interactive tool built in Excel for maximum usability and enabled users to assess the affordability of the programme to potential commissioners. Right, so that's how we did it. What were the results? Now, as you can see, here's some examples of staff and patient sentiment. So we can say that both groups appreciated the intervention, and by extension that it was accepted by both groups. In the bottom right, you can see that the burden on secondary care was reduced and that this reduction in turn provided value for money. Now, top left shows volumes of patients tested and treated, and also that these numbers are much lower than you might expect based on an eligible population of 43,000. I mentioned during the introduction to the case study that this was a reactive programme, and this proved to be a key issue in relation to implementation. Firstly, it was incumbent upon people to present to their GP. This required winning hearts and minds, as well as redesigning the patient pathway. On top of this, antivirals cannot be routinely prescribed in the community. Only once the letter from the Chief Medical Officer is published can community pharmacies order and prescribe antivirals. All this means that, with all planning in the world, you still have a very small window to educate people that the new method is available. You can only tell them the method is available once it is, i.e. after the CMO letter is out, and it requires immediate action by patients with pretty much no time for them to adjust. As if that wasn't enough of a challenge, the flu season for 22-23 saw a very sharp spike for a relatively short period of time, and that meant that once all the comms were fully deployed, the main spike had already passed. Now, you'll have noticed that none of this that I'm talking about is included in the slide deck, and that's because it doesn't fit neatly into methodology, results, etc. But what would have happened if this wasn't well understood? Well, fortunately, we don't know, but it would have resulted in an evaluation which missed a key element around implementation in the real world. Our evaluation placed great importance on understanding the levers for and the barriers to success, and it meant that these emerging themes could be identified early on, be fully understood, and be described in the recommendations for future rollouts. Now, before we move on, there is one more conflating factor to consider. There are no statistics for the amount of flu circulating in the community since there's no community testing. The best data available is the consultation rate for influenza-like illness, or ILI. ILI is based on a variety of factors, including patient behaviour, whether they present, expert opinion, whether or not the GP feels the symptoms are influenza-like, and data quality, is it coded as such. Now, ILI can be and was used, but it's important that its limitations are not only described in the findings, but also understood by both the evaluation team and the implementation team. So, overall, the flu test and treat community pathway had a positive return on investment, with benefits outweighing costs by 12-1. The evaluation findings supported future funding such that 2 further rollouts were commissioned the following winter. Now, with everything we've learned from the programme and the evaluation, what can we say about how it addresses the challenges listed at the start of the session? So we can say there was investment in primary care to address unmet need. And we can also say that it was able to improve access by changing the patient pathway and introducing new technology. And we can say that both staff and patient satisfaction were improved as a result. And the message I want you to take from this is not to stop at the results you have. Always make sure you apply them to the situation and ensure you answer the objective or the ambition. You have to make sure the evaluation is sufficiently expansive to deal with the inevitable follow-up questions, but don't lose sight of the objective and always make sure you answer it. So that was our 2 case studies for today. Hopefully there were some useful examples in there that you can use in your own work. So let's summarise what we can apply from those case studies we shared. The approaches used for evaluating in acute care cannot always map across to out-of-hospital services. Non-acute settings differ from acute primarily because acute is set up to offer short-term care of conditions with sudden or severe onset. Community care, by contrast, tends to be set up to support long-term needs, and seen this way, primary care is the ultimate delivery method of long-term care, albeit we don't often frame it this way. Now, make sure your evaluation approach is aligned with and will best highlight the benefits of your programme in the care space. A prime example would be that if you're aiming to improve patient sentiment, ensure you have a qualitative element. Pathway mapping is essential to understand the ecosystem within which your programme will exist. This will be arduous and you'll need to decide on the logical limits. Moreover, it's necessary to ensure you fully understand the benefits that you might create. So here, consider how the setting impacts on the pathway, and in primary care, there will likely be loops in that pathway. Think about the time frame over which you will see your benefits. Is there a short-term cost which will create a longer-term benefit? And don't limit yourself to immediately recognise benefits. There could be much more wide-reaching benefits. Just be careful to ensure that your rationale is sound. This is particularly important in primary care, where costs may occur over both a long time frame and over a wide range of different cost streams and areas. And lastly, think about the data you will need and how you will get it. Primary care data systems may not always talk to each other as you expect, or be coded exactly as you expect. It can take a long time to work through IG requirements, and the alternative of using aggregate data, there will be a data lag. So let's summarise then. 4 things to think about when evaluating a project. A project outside the acute sector. And these are the 4 main points we'd like you to take away today. So number 1, how easy is it to implement? What, if any, were the blockers, and how can these be eased? Moreover, do you need to know how people perceived both the project itself and the implementation of it? 2, does the project reach everyone immediately, or will uptake increase over time? How does this impact your perceived benefits? 3, if undertaking health economic analysis, ensure it matches the setting and the pathway in terms of scope, time frame, and benefit streams. And 4th, lastly but not least, when done well, evaluation can be a catalyst for growth. It can provide the evidence you need to answer the challenges which potential users and commissioners will inevitably pose. Okay, so that brings to an end those two sections. I'm just having a look. I can't see that there are any questions at the moment. So it could be a technical issue, or it might just be that it's a bit daunting to ask questions in a public setting like this. I know we've given you a lot of information in a very short time. I will give you some links in the Q&A section in a moment. So if you do have any other questions that you come up with in the coming days, do get in touch. We really hope you've enjoyed this workshop. As we mentioned earlier, this is the second in a series. So here is the full list of subjects we're planning to cover. If it's piqued your interest, there's links to workshop recordings and to our Eventbrite page, which has more details on each workshop, as well as sign-up instructions. Okay, so that's the end of today's presentation. If you do have any questions which you don't want to ask here or would like to get in touch in the future, there's a range of options for you. I will post them in the chat in a moment. But in the meantime, thank you so much for your time today, and we look forward to continuing the conversation with you in the future.